Welcome to Basic Dysrhythmia Review course. This course is a recording of the EKG class that was previously done yesterday or today. We're going to be reviewing the content, so you can also review it at your own pace. So we're going to be discussing the basic electrophysiology of the conduction system. We'll talk about the series of events related to the cardiac cycle. We'll describe the significance of individual waveforms in the relationship to the cardiac cycle. We'll verbalize ECG characteristics of rhythms originating from the SA node, from the AV node, and the bundle branches / ventricles. We will verbalize the difference between PAC, PJC, and PVC. We'll describe the distinguishing criteria for different types of heart blocks. We'll name the 3 common modes used for pacemaker. We'll also talk about the pacemaker malfunctions, and we'll talk about the names of the lethal rhythms. There is practice strips at the end of your packet that you can also do at another time on your own. The answers are on the very last sheet. Let's begin. So our basic electrophysiology. In our heart, we actually have a conduction system. Within that, we have 3 pacemakers. Each of these pacemakers have their own intrinsic rate. So the SA node, if it's working the way we expect it to be, would be pacing at somewhere between 60 and 100 beats a minute. The AV node can take over if the SA node is no longer functioning properly, and it will have its own rate of 40 to 60. Lastly, we can have the ventricles or the bundle branches that can take over, and that takes a lot of time for electricity to get through that very thick muscle, so the rate is considerably slower at 20 to 40. Here's a little animation of what we would expect the electricity to look like if everything's working properly. So all of this translates into waves. If you'll notice in our basic EKG class, we will never refer to measuring just the P wave. We're going to be looking at the PR interval, and that's indicated by the orange line at the bottom. Next, we're going to be looking at the QRS complex, and then we'll also be looking at that ST segment to make sure it's nice and flat at the isoelectric line. We will also be talking about the isoelectric line, which is where we have the absence of electrical activity. Okay, anything above this isoelectric line would have a positive deflection, and anything below is a negative deflection. You can see the isoelectric line is marked by this red line right here. During this time, we also have what's called a depolarization and repolarization cycle. At the very top, you'll see the P wave is highlighted, and that's where we have atrial depolarization. We would expect to have atrial contraction at this time. Then the QRS complex would signify ventricular depolarization, and the ST segment followed by the T wave would be your ventricular repolarization. We also have what's called refractory periods. The first one we're going to talk about is the absolute refractory period. That is this area that's indicated by the red or the blue highlighting, sorry. You can see it begins at the very beginning of the QRS all the way halfway through the T wave. During this time, what is happening is if the heart is already in this QRS complex, it's not going to respond to any other stimulus. It's going to ignore it. It's kind of like whenever you're talking to a toddler and they just first figured out how to plug their ears and ignore all that's going along, they are going to be able to ignore you and not respond to anything. The next part of the refractory period is a relative refractory period, and that is in this kind of pinkish red area. This area is actually where the heart will respond. So if we all of a sudden have some stimulus from somewhere like the SA node, it's going to go ahead and pick up and carry on its new whole complex at this time. Now, it can be a little dangerous if we're at this time. We want to make sure that the heart is getting its full resting phase, and if it does have stimulus at this time, you could also have the R on T complex, which can be dangerous. So we're going to continue on with waveform segments and intervals. So this is a presentation for all the way we expect P waves to look. We expect them to be normal, but on occasion they could be notched, peaked, or inverted. All of these would still be considered P waves. Our ST segment, we would like to see normal, which is flat at that isoelectric line. The second picture, you can see you have some ST depression, which indicates some myocardial ischemia. The last one you can see has ST elevation, or the fireman's hat. That means that we are having an active STEMI or an MI. Our T waves can have a couple of presentations as well. The first one will be considered normal. The second complex you see, it has the T wave is almost as tall as the QRS complex. The third one, it's inverted, and the last one, it's showing that it is hyperacute. You'll also notice the hyperacute has an inverted QRS. That's just because we're looking at it from a different view. We want to also be aware of the QT interval. This is inversely related to the heart rate. It's normally less than half of the length of the R to R interval. Here's our EKG graph paper. This is a clinical diagnostic tool used to help measure activity, and much like graph in algebra, you have your X and Y axis. It measures different things. From the bottom to top, it's going to measure electricity or voltage. From left to right, it's going to actually measure time. So one small box measures 0.04 seconds. Right here, you can see the little blue box. And if you have 5 of those little boxes all together, it's going to create what we call one big box, and that's going to be 0.2 seconds. You have to have 30 of these big boxes in a 6-second strip in order to have the full 6 seconds. So let's talk a little bit about measurements. So if we have a PRI where we start our measurements at the very beginning of the P wave and we end it right before the Q complex begins, this measurement should measure somewhere between 0.12 and 0.20 seconds. If it's a little bit longer or normal, then we're knowing it's coming from a different area, and we'll work with that. Our QRS, what we considered normal, would be at the very beginning of the Q all the way to the very end of the S when it comes back to the isoelectric line, and we expect that to be somewhere between 0.04 and 0.10 seconds. So let's just do a little practice. If you go ahead and make your marker at the very beginning of the P wave, go ahead and make your second marker right before the QRS begins, and count the boxes in between. I count 4. So 4 times 4.04 for the seconds, or the number of boxes, would equal a measurement of 0.16. I'm going to go ahead and put up the next marker for ending the QRS complex. I see about 2 to 2.5 boxes somewhere in there. So that times 4 gives you 0.08 to 0.10 seconds. So let's talk about the different types of leads. In lead 2, we're looking from negative to positive. In our modified chest lead, or MCL, we're looking from positive to negative deflection. So what's happening is we're just changing our point of view. If you had someone tell you, stand at the foot of the bed and tell me everything you see about your patient, you might miss a couple of things like behind the ears or the very top of the head. So if you're able to change your position, your view, and maybe stand at the head of the bed and look down, you'd have a different perspective. Now we can keep changing our perspectives and turn our patient over and go on the other side of the room, but then that's a 12-lead class, and we're not talking about that today. We're just talking about our 2 most common leads. The only thing that changes in here would be our QRS complex. As you can see in both of these, the P wave and the T waves are upright. The only thing that changes is that in the modified chest lead, the QRS is inverted. So let's talk about the steps required in our EKG interpretation. First of all, we need to look at the whole rhythm, okay? We need to look at the atrial rhythm separate than the ventricular rhythm. We need to see, is it regular or is it irregular? From there, we can determine what the rate is, again, separating atrial and ventricular rates. Then we can look at the intervals. Every time you see a P wave, do you see a QRS with it? Then you want to go back and look at anything that just doesn't look right. Are there any beats that are premature? Is there any missing beats? Is there any beats that look a little bit different than the rest? If you need to, go ahead and circle these at the beginning so you can acknowledge them, but come back to it as your last step. So this is how we're going to determine our rhythm. First, we're going to find a P wave, and we're going to find the next consecutive P wave, and then we're going to count the number of tiny boxes between for the rate. But right now, we're just looking to see if it's regular. So I'm going to take my calipers and move them to the next P wave to see if I have to adjust them at all. If I don't have to adjust them at all, then I know that I have a regular rhythm. If I have to keep adjusting them, I know that it is irregular. I'm going to repeat the same thing for the ventricular response. I'm going to find it at the very top of the R waves, and so on. Sometimes those P waves are really hard to find. So some things I found other people do that have been successful is marking a little dot where they think the P wave is. So if you can actually see the sequence of the waveforms, it looks like everything's kind of jumbled and out of order. The first wave I see is a QRS, then a T, then a P, then another P, a QRS, and a T. As you can see, this is really not the right order, so we know that we're dealing with something a little bit weird. We have less amount of QRSs as we do have our P waves. So here I know I'm dealing with the 3rd degree heart block, but go ahead and put the little dot above where you think is the P and see if it does march out. Now, if we determine our rhythm is irregular, we're going to count the number of P's in a 6-second strip and multiply by 10. We have to make sure that we only have 6 seconds for this to work, okay? So if I have 9 P waves in a 6-second strip, then I'm going to multiply by 10, and then I'm going to go ahead and get a rate of 90. I'm going to repeat the same thing for the ventricular response for the R waves. Now, a lot of people like to apply this rule to regular rhythms, and it just doesn't work. So you have to do a little bit of math here or use the grid that I'll show you in a couple of slides. So for atrial rhythm, again, you're going to find 2 consecutive P waves, and you're going to count the number of boxes in between and divide by 1,500, okay? You'll repeat the same thing for the R waves. For example, if I had 18 boxes between the 2 consecutive P waves, I would do 1,500 divided by 18, and that would give me a rate of 83. So let's do a little bit of a practice. Here, I made sure that I have 30 big boxes, and then I have a 6-second strip. So I'm going to go ahead and count the number of just R waves for the sake of time to count to see how many we have, okay? So I count 3, 4, 5, 6, 7, 8, 9 of them. So 9 times 10 would equal 90. So that is our rate, 90. I would repeat the same thing for the atrial rhythm as well. Now I have a regular rhythm. For this one, I want to make sure that I don't have to keep adjusting my calipers. In this case, I didn't have to when I measured it out. So I'm going to find my first P wave and then my second P wave and count the number of tiny squares in between. And sometimes I found if you count these little green slashes through the groups of 5, it makes it a little bit easier and you're not accidentally double counting. In this case, I have 19 small boxes, so I'm going to do 1,500 divided by 19. And then I'm going to repeat the same thing for my R waves, and that's going to give me a rate of about 79. So if I look at this chart, I'm going to look on the left-hand side for my number 19, and then I'm going to look all the way to the right where it says the rate, and then you can see here that my rate's 79. So you don't have to actually do the math. You can just use this chart. Now, I have a lot of people that get worked up over what happens if I have a rate of 43 or if I have 43 small boxes. Well, because of the associative property of multiplication and division, 4 times 5 is 20, 5 times 4 is 20, 20 divided by 5 is 4, and so on. You can see that if we go to the right-hand side and look up 43 boxes and look to the left, the answer would be 35. So don't get worked up if you lose track of numbers on the far left. It's okay. You can still look at the right-hand side. Right. So now we're going to discuss sinus rhythms. All of these rhythms are coming from the SA node, and it's very important to understand that. That's the only way we can have a sinus rhythm. For a sinus rhythm basic concept, all you have to do is look at one complex. So you need to have a normal measuring PRI and a normal measurement of a QRS. That is what makes the sinus rhythm because we know it's coming from the SA node. So once we know that we have that in place, we have a couple of extra rules we can add to it. If we have a rate over 100, it has to be called tachy. And I have on here with 2 exceptions, and that would be your AFib and AFlutter, which would be considered uncontrolled. So rates that are less than intrinsic rate or less than 60 would have to be called Brady. So if we had everything there just a little slower, we would still go ahead and call that rhythm Brady. So our normal sinus rhythm, this is what we want all of our patients to be, but very few of them are because they're in the hospital and they're sick. So again, the electricity starts in the SA node. The AV, the atrial and ventricular rate are within normal limits. Your PRI and your QRS should measure normal, and your rates should be somewhere between 60 and 100. So variations of this would be sinus Brady, which is when our rate is less than 60, or sinus tach, which would be over 100. If you notice, we cap it at 150 because once we start going faster than 150, we lose the ability to see P waves. And at that point, we're starting to think SVT. Okay, our next one we're going to talk about is sinus arrhythmia. This has the same rules as sinus rhythm, except the rate can vary with respiration. So as they breathe in, the heart beats a little faster. As they exhale, the heart beats a little bit slower. As you can see, everything gets paired together through the vagus nerve. So the atrioventricular rate usually averages out somewhere between 60 and 100. It's going to be irregular, so you would have to use your 6-second rule in order to calculate that. But we would, again, somewhere between 60 and 100 expect it to be. So sometimes you have special features of a rhythm like sinus pause or sinus arrest. So this would have all the same rules as sinus rhythm, except a beat is just paused or skipped. As you can see here, if I were to put my finger and cover up this sinus pause, you'd never know it's missing a beat. Because of this, you have to identify the underlying rhythm. If you call the whole strip a sinus pause or a sinus arrest, then we are actually missing out on the whole concept. You're just kind of pointing out one special feature. For example, if you had a car and it had a dent in it and you're pointing out the dent, you wouldn't be telling me much about the car. You would just be telling me about the dent. So I have to have the whole description of the rhythm. Right. Next, we'll talk about atrial rhythms. So these rhythms are not necessarily coming from the SA node, but somewhere in the atria. So they'll have similar characteristics. The QRS will be nice, normal, and narrow. But they don't necessarily come from the SA node, so they may not be necessarily regular or look quite the same. Every rate that is over 100 has to be called tachy, except for AFib and except for a flutter. This we will now call uncontrolled. It wouldn't be wrong to call it tachy, but for the purposes of testing, you want to make sure that you mark it uncontrolled if it's over 100. If it is under 100, then it would be considered controlled. So the first one we'll look at is our narrow complex supraventricular tachycardia. If you notice, it says supra, which means above, so above the ventricles. So we expect a narrow complex with our QRSs. You lose the ability to see P waves. So what you are seeing here is QRSs and then Ts that are following it. This is the rhythm. This does need some pretty quick intervention. So it's very important to make sure you're able to identify that. The rate is going to be starting at 150 and it's going to go on up. But with narrow complex SVT, you're always going to have a narrow complex for your QRS. Okay. Next, we'll see a flutter. A flutter is a very organized chaos. As you can see in the image, we have two little areas, and it could be more than two, that are bouncing back and forth the electricity. It's very organized. I know exactly where the next F wave is going to come. In this case, we don't have P waves, we now have F waves. So it looks a little bit like a sawtooth. I've heard people say it kind of reminds them of a butterfly flapping its wings. You know exactly when it's going to flap its wings. It's very predictable. What's a little bit different here is how we're going to actually measure. So you know that your atrial rate is going to be fast. It's going to be somewhere between 2. Okay. We're not going to have a PRI because there is no P wave. These are now F waves. Okay. Your ventricular response can be regular or it can be irregular. If there's two F waves in between complexes, it might be regular, but if it's 2 and then 3 and then 2, it could be irregular. It could be either way. If your ventricular rate is over 100, it's going to be considered uncontrolled, and if it's under 100, it'll be controlled. So what we need to do is figure out how to measure that. You'll follow the same, irregular or regular for the ventricular response, but for the atrial response, it is measurable. So what you're going to do is find 2 consecutive F waves. Count the number of small boxes in between. In this case, we have 5. We're going to use our 1500 rule because it is regular. So our rate in this strip is actually 300. Okay. AFib is a little bit different. This is like a little bit of unorganized chaos where we have a bunch of cells in the atria that are all firing at one time, and it's sort of competing for leadership, and it's not really working out. So what we see on the EKG strip is a bunch of little wiggly, messy lines. Our atrial rate is somewhere over 300, but it's so fast we're not going to bother measuring with it because it's not really organized. Your ventricular response is always irregular with AFib. So if you're stuck between AFib and a flutter, you know 100% AFib is always going to be irregular. And this will also follow the same rules as if it's the ventricular response is over 100, it'll be uncontrolled. And if it's less than 100, it'll be controlled. The next section we're going to talk about is junctional rhythms. Junctional rhythms all have electricity starting at the so it's going to look a little bit different. So in order for it to be considered junctional, it has to have a narrow QRS, and the P wave has to present one of these four ways. It has to be either inverted, absent, retrograde, meaning after the QRS complex, or a short PRI. And what I mean by short is it's going to be less than 0.12, which we consider to be normal. So our junctional rhythm has all the same rules we just talked about with the junctional rhythms. As we said earlier, we expect the junctional rhythm to be somewhere between a rate of 40 and 60. So that's what we would expect normal. If it was faster than that, then we'd have to consider it accelerated, and it would be a rate of greater than 60. So what we're looking here is, if you look at the measurement, the QRS is still nice and narrow. Okay? And it's also very regular. So anything that has a rate that's greater than 100 has to be called tachy, except for AFib and A-flutter, which we called uncontrolled. The same thing is true of junctionals. So anything faster than the intrinsic rate but less than 100 can't be called tachy. So that's when we're going to be using the name accelerated, meaning it's faster than the intrinsic rate but less than 100. So here's your accelerated junctional. So it has the same rules as junctional, but the ventricular rate is going to be somewhere between 60 and 100, or 99 for you type A personalities. In this case, we have no P wave, but if the P wave was inverted or retrograde, we could also do that. Here we have junctional tach. You can see the P wave here is inverted. Again, our ventricular rate is somewhere between 100 and 149 or 150. If it starts to go faster than that, we lose the ability to see the P waves, and we're going to go ahead and call it SVT. So just be looking at that rate if you do have something you suspect is junctional. Next, we're going to discuss ventricular rhythms. Okay, so here we are bypassing the first two pacemakers, and we have the whole ventricular part of the heart that's trying to take over and support. So our SA node and AV node are not working. So our QRS now has to be wide and regular. We expect the intrinsic rate to be somewhere between 20 and 40, and it's got to have bundle branch or ventricular in the name. So the first one is idioventricular. This is what we consider a dying heart, and it will become lethal if it does not have intervention soon, but we are not going to consider it lethal for this specific test for now. So it follows all the same rules as the ventricular rhythms. So you're going to see it's going to skip the P wave. It's going to have a wide QRS. And then sometimes I hear people saying that the idioventricular rhythms happen to look like chairs. And that is absolutely okay. We kind of expect that to have a little bit of a different look because it's taking a little bit longer to get through the ventricles. Okay, so we also have accelerated IVR. This is where we have idioventricular, the ventricles are taking over, but it's faster than that rate of 40, but less than 100. So these also look like maybe fancy airport chairs. They just have a little bit of a different look to them. Again, no P wave. Now we'll discuss ectopy. So we have our premature atrial complex. So everything's going fine, and all of a sudden we have this little beat that's a little off than the rest of them. So if you kind of look at everything else, it looks like we have usually a normal sinus rhythm, but then this one beat that's just out of place. How you're able to tell a premature atrial complex is by one, it has a narrow QRS. Next, we're going to look at the measurement of the PRI. As you can see, the P wave might look a little bit funny, but the PRI actually measures somewhere between 0.12 and 0.20. So that's what we expected would be appropriate. You would want to make sure you name the underlying rhythm and come back and go ahead and say this would be a normal sinus rhythm with a PAC. A PJC is similar, except it's going to follow the same rules. It's going to have a narrow QRS, and then the P wave is either going to be absent, short, retrograde, or inverted. In this case, it's retrograde. It's right after the QRS. But again, you have to say what the underlying rhythm is and then go back and discuss that it has a couple of PJCs. This rhythm would actually still be considered regular. You would just ignore the ectopic beats and kind of work around them. Next, we have our PVCs. So our PVCs is a little bit of extra cells in the heart that are just sort of, again, competing and trying to butt in when they kind of aren't invited. So they actually have a wide QRS because they do take place in the bottom part of the heart. And then they have an opposite kind of T wave that kind of looks kind of a little bit different as well. So it is a premature beat. It follows all the same rules as ventricles, except it doesn't have to be regular. It can be in the same direction or it can be in different directions. So in this case, we have what's called multifocal and unifocal. So this top strip you see is actually unifocal PVCs, which means we are having all the electricity is coming from one focus, one little part in the heart, and that is continually causing that irritation. The bottom strip you can see is actually having multifocal, which has some of the PVCs are pointed up and some of them are pointed down. That's coming from multiple foci in the heart. A little bit different places can cause a little bit different looking PVCs. Sometimes they happen in pairs. So if you have a pair of PVCs that occur consecutively, we're having increased ventricular irritability. And we need to watch that very closely because it can turn into a run of VTAC, which would be 3 PVCs in a row. So we want to make sure that we're watching that closely because it's really easy for it to turn into a run of VTAC. Sometimes it can happen in patterns. So it could be every other beat is a PVC, which would be considered bigeminal, bi meaning 2. Every third beat would be a trigeminal PVCs, and every fourth beat would be quadgeminal, every fourth beat. The next section we're going to talk about is lethal rhythms. So if you fell asleep on me, it's time to wake up. You need to make sure you are aware of your lethal rhythms. So here is your basic concept. Go to your patient. They are dead or dying. Okay? It's very important that you're aware of what these are. This first one is considered VTAC. You have what looks like tombstones. This has 3 or more PVCs in a row. They follow the same rules as ventricular rhythms, except the rate is going to be over 100. The ventricular activity is measurable, so we'll talk about that in a little bit. But I want you to be aware of this look that looks like tombstone. It's very, very important that you can see the QRS is wide and it comes from the ventricles, okay? Remember, 3 PVCs in a row would indicate a run of VTAC. Then we have VFib. This is a little bit more chaotic. So we have a bunch of little cells in the bottom of the heart, and they're all fighting and they're competing against each other, competing and competing. And really, we don't have organized, good, meaningful activity. So we just have this fibrillation or this quivering. Nothing about this is measurable. We just know we need to get to our patient and have some sort of intervention very quickly. The next one is asystole, and we tell you to check in more than one lead because sometimes this can be mistaken, but really first you need to go and check and see if your patient has a pulse. Now this class is not about interventions, just know if you see a flat line then you have no electricity going on there. So you either need to put your patient back on the monitor or make sure that you actually do have asystole. The next one is going to be, let me back up. Asystole should not be confused with fine VFib. As you see in the bottom here, there is some electrical activity going on. It's not really defined like the screen before, but it does have some activity. The last lethal rhythm would be pulseless electrical activity, and we don't really test on this one. You could be tested on if you do have to take ACLS later on. It could be any rhythm, but then there's no pulse present. So just know that depolarization is not the same thing as contraction. It's actually an electrical event that is expected to result in contraction or a mechanical event, but doesn't always do it. So we call any electrical activity with on the monitor but with no pulse considered pulseless electrical activity or PEA. It is a clinical situation, not a specific dysrhythmia. Again, it could be a block, it could be sinus rhythm, it could be anything. We don't really know, however it shows up. Let's move on to heart blocks. Heart blocks, your basic concept would be that there is a block in conduction. So it can show up as a delay, a progressive delay, or a prolonged delay, even a dropped wave. So everything is starting in the SA node appropriately, and somewhere on the journey down there's some sort of delay or block. So the first one we have is the bundle branch block. Electricity starts in the SA node and it travels all the way down. Once it gets to the bundle of His, it only goes down one side, okay, the bundle branches, one side or the other. Now you don't need to know left block versus right block. That's a little bit more advanced. Just know you're going to see a wide QRS if this happens. So take a good look at this picture. You can see you have a P wave and a wide QRS. bundle branch block is going to be the only time that you see a P wave while you have a wide QRS there. This is a partial block, so we're going to identify the underlying rhythm first. So you would say, I have a normal sinus rhythm with a bundle branch block. And again, the only difference between a bundle branch block and a normal sinus rhythm would be the wide QRS. Next would be the first degree heart block. What's happening here is our PRI. It's taking too long from the electricity to leave from the SA node and travel down to the AV node. So it's consistently too long. So we know if a normal measurement is between 0.12 to 0.20, then it has to be measuring greater than 0.20. Again, it's consistently too long every time that we do see it there. And again, this is a partial block, so it would need to have the underlying rhythm first. Usually it's going to be some kind of sinus rhythm, sinus brady or so, but the PRI is just too long. So your bundle branch block and your first degree block are actually the variations of what a normal sinus rhythm would be. Next block would be a second degree type 1. So here, your P's are regular, but your R's are irregular because what's happening is there's a progressive delay until the QRS is completely dropped. So you have longer drop, and then it's recycling again. So we're going to have to use two different ways of measuring our rates here. So our P waves are regular. We're going to use our 1500 rule. And our R waves are irregular, so we're going to have to use our 6-second rule. So this would be a prime example of why we look at atrial rhythm versus ventricular rhythm very separately. You do not have to say the underlying rhythm because the second degree type 1 is actually the name of the rhythm. In a second degree type 2, your atrial rhythm again is regular, and your ventricular rhythm could be either regular or irregular. It could be either way. So in this top picture I'm showing you, it is irregular. And the reason why we say it's irregular is because it's missing two QRS complexes. But as you can see, the SA node is firing regularly. We know exactly where the SA is going to be giving us the P wave, and we don't know when the next QRS is coming. Now, if we stretch this out over a longer strip, we could probably guess, but we only have 6 seconds to work with. Down here, the second strip, the atrial is regular and the ventricular is regular. Because the QRS is dropped every other one, it's happening in a pattern. So just pay attention with those secondary type 2, whether the ventricular response is regular or irregular. The hallmark sign of a secondary type 2 would be that your PRI is identical every time you measure it. You shouldn't have to adjust your PRI measurements. Next, we have our third degree or a complete heart block. So this strip right here has your P waves are regular. Your QRSs are actually regular as well. So some might say, I don't really see regular P waves, but as you can see, I have a couple of hidden P waves. Those P waves are hidden inside T waves or QRSs or something like that. And what's happening is sometimes it gets us a little confused. So I want you to play a game of what if. What if this really was a P wave? And adjust your calipers and see if you can march out your P waves, because chances are it does march out. So we have two different ways of figuring out whether it is what type of third degree heart block. We have the bundle branch and we have the AV level. So take what you know already. Third degree block at the AV level is going to have characteristics of the AV node. So it's going to have a narrow QRS and it's going to have a rate of somewhere between 40 and 60. Our bundle branch, our third degree at the bundle branch level, is going to have wider QRSs and the rate's going to be a little bit slower. As you can see, we marked all the P waves. We've got about 2 hidden P waves as well. The first one's hidden in a T wave and the second one is hidden in a QRS. Remember, you're not going to see those hidden T waves because of the refractory or the absolute refractory period. Sometimes you'll not be able to see it, or the relative refractory period, you'll be able to see it, but it might look a little bit different. So this bottom strip again is no PRI is measurable. Your QRS is wider than 0.12, which means it is at the bundle branch block and the rate is somewhere between 20 and 40. So an easy way to wrap this up for heart blocks would be to kind of remember the letters T, G, I, F. So our first degree, our PRI is too long. Our second degree type 1, our PRI is getting longer and then it'll drop. My second degree type 2, my PRI is identical when it is present. And my third degree, my PRI is funky, fighting, or you can't figure out what in the world it is. It could be a third degree. Try that little trick and see if that helps you out with remembering the different types of heart blocks. The only one that's not on here is the bundle branch block. But if you remember with bundle branches, your QRS is going to be wide. You should be fine. All right, so pacemakers is our next topic. So rule of thumb, your pacemaker should have a little spike right before the waveform it's triggering. So depending on where the impulse started, it will reflect on that waveform. So a pacer spike does not indicate mechanical capture. So don't assume just because you see a pacer spike and then it's flat that it does have meaningful activity. It could just mean the pacemaker went up, but it did not create the actual complex we want it to. So here you go. This is atrial pacing. This is somebody who is 100% atrial pace. There's a pacer spike, then a P wave, and then we have our QRS and T. You can see from the picture on the far right, there's a little lead that goes into the atria, which is where all the electricity is starting. So 100% atrial pace. Ventricular pacing, we have to go back to what we already know about anything that has to do with electricity starting the ventricles. That means we're going to have a wide QRS. So our pacer lead goes all the way to the ventricles, and we have a pacer spike right before the QRS. We have a wide QRS, which we expect. It would be an expected finding. You can see noticeably we are missing the P wave, and that's okay because we're kind of bypassing the atria here. So we have atrioventricular pacing. This is the only time I'm going to tell you to go ahead and decide that there is a P wave even if you don't see it. If we see a pacer spike right before the atria and there's not a P wave, it's okay. We're just going to go ahead and take that measurement anyway. So you'll also expect a wide QRS as well. So to measure your PRI, you're going to go from the two pacer spikes closer to each other, and then you're going to do your measurement from there. Again, you're going to go ahead and accept that it's a P wave when you're measuring your PRI. Don't worry about it not being there. So sometimes these little buggers make a mistake. So let's talk about those malfunctions. The first one is failure to capture. So the pacemaker fires, but it doesn't have the appropriate response. So you can see in the top strip, that third beat right there, the pacemaker fires, but there's no QRS to follow. That can be problematic very soon. If you look at the bottom, here we have a systole with the pacemaker just continually going off. This could be potentially lethal if the heart's not reacting to the pacemaker stimulus. So this is failure to capture. I like to tell a story when we talk about failure to capture. This is close to when you're playing like flag football and you're running after somebody and you fall down right before you capture their flag. You tried, but you didn't quite capture it. You can't really count it as a beat because it is a skipped beat, but you did try. So, high five, but it doesn't count in the grand scheme of things. Failure to pace. This is where the pacer should have fired, but it didn't. There's no artifact present, so it's just the pacemaker really should be working. There's not a reason for it not to. In the top picture, you can see we have a pacemaker that is set at 60 to go off if the heart falls below 60, and actually the heart rate is about 40 and it's not firing. The bottom one is another type of failure to pace. What's happening is we have the pacer spike for 2 beats, and then we just miss a beat, and then it picks back up again. For the purpose of the exam, you would probably be able to see the one on the bottom more so than the top one because we'd have to give you a lot of backstory. The reason why I share this with you is you may get to your floor and find out that your patient has a pacemaker and they're not actually pacing when they really should be. That pacemaker would need to be interrogated. Oversensing is the next pacemaker malfunction. This is where the pacemaker detects artifact and it says it's meaningful activity, and so it doesn't get involved when it should have. So I like to tell a little story. If this is like my 5-year-old little daughter who is in the kitchen and she is like clinking around with dishes, and I'm sitting down on the couch reading a book and I'm thinking, oh, thank goodness, someone's washing dishes. At least I don't have to do it. That dishwashing activity is not really good, meaningful activity. It's actually going to be a little dangerous because she could be breaking dishes. She could be not washing them with soap, or maybe she's flooding the kitchen. Who knows? It's not going to be good, meaningful activity. So I'm oversensing that meaningful activity is happening, but it's really not happening, and it's really going to kind of bite me in the end because I'm not having good, meaningful heartbeats. but there will be some sort of artifact in place. Now, don't confuse oversensing with undersensing. This is when the pacemaker does not recognize that the patient's own electrical activity is happening and it fires too close to the intrinsic beat. As you can see, we've got 2 beats that are started by a pacemaker. The 3rd beat is on its own, the 4th beat's on its own, and that 5th beat right there is way too close to the patient's own beat. It didn't quite have enough time to go through the full resting cycle. So it can be a little bit dangerous. And then you can see the next couple of beats also are paired way too close together, but there isn't capture with the pacemaker spike because of that refractory period. So the difference between oversensing and undersensing is the pacemaker is firing too much, too close to the patient's own beat. Undersensing would be the opposite. So for additional practice, here's a couple of resources. As Advent Health, we don't endorse any of them, but there's just a couple of things that we have found on the web that we found really helpful. The first one, the first 2 links right there are actually ones that you could customize where you need some additional practice with. So if you were struggling with just junctionals, you could go ahead and just do just the junctional portion and do some practicing. The third one, SkillStat, is actually a rotating ECG simulator. So you have to be a little bit more focused on identifying and not as much as measuring, but those tools are there for you. And then we also have ECG interpretation made incredibly easy by from Lippincott, Williams, and Wilkins. That's a really great tool. It's actually more of a longer term tool. It's not something that you could read overnight, but there is some additional things for you. So if you have any additional questions for EKG, please reach out to your program manager. We really want to help you be successful, and thanks for listening.